Good evening, everyone. We are here for the session of our biological series. Today's topic is on administration of neuropsychological questionnaires by our speaker, Mrs. Sheetal Gupta. Presently, she is a PhD student from Swami Vivekanand Yoga Anusandhan Samasthana. Her master's is in yoga and mass communication. She had done certification courses in yoga asana, pranayam, meditation, naturopathy, and yoga diploma from All India Nature Cure Federation. She has done diploma in public relation from Bharatiya Vidya Bhavan, Delhi. Along with Mrs. Sheetal, we have a very special guest as a commentator for today's presentation, Dr. Swati Gujral. Dr. Gujral is a clinical neuropsychologist and currently transitioning from research, postdoctoral fellowship, and clinical center of excellence to a faculty position as an assistant professor of psychiatry at University of Pittsburgh School of Medicine. Her clinical work and research are jointly committed to assessing and treating cognitive dysfunction and depression in older adults. Her clinical translation research program targets brain health in those with depression and comorbid cognitive impairment in late life, incorporating markers for physical and brain health, along with clinical symptomology and neurocognitive function. The goal of her research program is to optimize brain health in older adults with psychiatric and cognitive comorbidities using lifestyle interventions. So, with this introduction, I'm pleased to begin our session and request Mrs. Sheetal to start your presentation. You're not audible. Please switch on your mic.
Sorry. Good evening, everyone. My name is Sheetal, and I'm a student of SVYASA Bangalore, a PhD student. I'm in a learning phase of a about neuropsychological questionnaires. So, uh, please bear me if I'm making any kind of a mistakes, and maybe Swati ma'am can correct me wherever I'm going wrong. Today's topic is administration of neuropsychological questionnaires. So let's first understand what is neuropsychology. It is a field of study that seeks to understand how the brain process makes human behavior and a psychological function possible. Uh, it basically means to seeks to understand how brain, thought structure, neural network proceeds and controls behavior and mental processing, including emotion, personality, thinking, learning, remembering, problem solving, etc. Particularly in cases of how damaged or diseased brain structure alters behavior and interact with mental and cognitive function, where we do the assessment, diagnosis, treatment, and rehabilitation. Most common activity of clinical neuropsychology is psychological assessments. What are neuropsychological assessments? Neuropsychological assessments are specifically designed tasks that are used to measure the psychological functions known to be linked to a particular brain structure or pathway. Neuropsychological assessments are used for research into brain functions and in a clinical settings for a diagnosis of deficit or a disease. Neuropsychological uh, test assessments can also be said as assessments of cognitive ability, determination of individual current level of functioning. It also identifies the strength and the limitations of that person. How we perform the neuropsychological tests is assessments would be clinical interviews, observation data, review of records, standard testing. Neuropsychologist basically looks for the health of the brain, affects thinking and skill behavior. These assessments are usually done with a pencil or a paper, or done on a computer, or by a neuropsychologist, just by a series of questions. These neuropsychological tests are administered one-to-one, a single person working with a examiner in a stress-free environment. These tests are cognitive tests and non-cognitive tests, which includes your language in cognitive testing, which would include the language, intelligence, memory, attention span, processing speed, executive functions like planning, execution, And in non-cognitive, it includes emotional, behavior, personality, quality of life, etc. What are the principle based on the neuropsychological is the localization view, which means specific area of a brain are responsible for specific behavior and psychological function. Refers to a concept that different area of brain controls different aspects and behavior. And globalist view means each area of brain has its own specialized area, but these work together to achieve a holistic function. Uh, it also includes the modular view where brain region, the models that specialize in a certain function often interacts with other models that may process information differently. A complex psychological function is controlled by several brain modules that are working together in a network. Levels of interaction is the brain models are connected in multiple levels. These models are organized in a global and local fashion. It also talks about the lateralization of the function. The lateralization of the brain function in the tendency for the same neural function or cognitive process to be specialized to one side of the brain or the other side of the brain. Like the left hemisphere is more of analytical and facts and logics, whereas the right hemisphere is more of creative imagination, feeling, uh, arts, etc. How is the neurophysiological evaluation done? Neurophysiological assessment is an assessment of how one's brain function, which indirectly yields information about the structure and function integrity of the brain. The neuropsychological evaluation involves an interview and an administration of tests. Neuropsychological tests are standardized, which means they are given in the same manner to all the patient and scored in a similar manner time and again. And individual scores on test are interpreted by computing with scores to that of healthy individuals of similar demographic background, which is similar like age, education, gender, etc., and expects to level of functionality. In this way, a neuropsychologist can determine whether one's performance on any given task represents a strength or a weakness of a person. Although the individual scores are important, the neuropsychologists look at all the data from the evaluation to determine a pattern or cognitive strength and weakness, and in turn, to understand more about how the brain is functioning. The structure of the administration is fixed structure or flexible structure. The fixed structure is same set of tests administered to each patient, whereas the flexible is selecting tests based on patient's manifestation. The fixed tests are time consuming, expensive, and irrelevant, whereas the flexible tests are biased, process, and not ideal for a large study. There are some of the neuropsychological assessment tests we'll be assessing today, which would be 6-letter cancellation test, perceived stress scale, state and trial anxiety, general health questionnaire, and trial making test. So 6-letter test is basically a test which has 22 columns and 14 rows, and there are around 6 target letters in it, as we can show it here. So there are 6 target letters. So in 6 target letters, the person will be given 90 seconds to actually cancel these letters, one by one. So that, and at the end of the day, we look at the total number of attempts after 90 seconds, and we'll subtract the wrong attempts the person has made, and the net attempts would be calculated. Cancellation tests require visual selectivity and motor response. It actually helps. A 6-letter cancellation test was administered to access functions such as selective and focused attention, visual scanning, and activities and rapid response of a person. The next test which we'll talk about is perceived stress scale. Perceived stress scale has around perceived stress scale, which has 10 questions in it. As it talks about, it actually analyzes the stress of a person. So it has 10 questions. It has negative questions and it has positive questions. The scoring is between 0 to 40. In negative question, it is the questions 1, 2, 3, 6, 7, 9, and 10 are negative questions, whereas positive questions are 4, 5, 7, and 8 are positive questions in it. But the when the scoring is calculated, it is forward scoring and reverse scoring. The negative questions are scored forwardly, like the 0 is always a 0, whereas 1 is always when the person is saying almost never. In negative, we'll be considering only 1 only, whereas in positive it will be the reverse order, that if the person scores person says 0, will only evaluate as 1, not as 4, because it's the negative scoring which we are supposed to do. So in perceived stress scale, it can be the if the level is between 0 to 13, then there is very less stress, which is low stress. If the scale counts for 14 to 26, it's a moderate stress. If it's more than 27 to 40, then it is high stress level with the person. The next is the state and trial anxiety test. This is the 20 question, it has 20 questions. Again, it has positive statements and negative statements in it. So positive statements in this are 3, 4, 7, 9, 12, 13, 14, 17, and 18. Whereas negative statements are 1, 2, 5, 8, 10, 11, 15, 16, 19, and 20. Again, the scoring is done in the same manner. The positive statements are scored as 1 only, whereas the negative statements are calculated from right to left instead of left to right. Like I can give you an example. Like, I feel calm is a negative statement according to the state and anxiety test. So if the person scores 1, it scores 4, that means in our calculation we'll be only calculating it as 1. So the higher the score indicates the more the stress of the person is. So if the person has anything which is less than 21 the scoring, then that means he does not have any kind of anxiety. Whereas if it is between 21 to 40, it is mild. Between 41 to 60, it is moderate, and 61 to 80, it is a severe anxiety. The person has severe anxiety. The next questionnaire is the general health questionnaire, which is basically talks about the quality of the life. It has 12 questions in it. It has, again, some positive and the negative statements. There are positive items and negative items. The positive items talk about the health, whereas the negative items talk about the id health. But the kind of question it has, we don't have to do a reverse scoring in this case. And the more the scoring is, the person has more on the ill health side. So anybody between 0 to 12 has a better health, whereas anybody between 13 to 24 is a fair health, whereas anybody between 25 to 36 is in a bad health condition. The last test which we're talking about is the trial making test, which is test A and test B. Both of them has 25 items, and it actually the A test is an executive function test which talks about the processing speed, visual scanning, whereas the trial B test is executive function, which is the shift of the attention span. Is both of them has 25 questions. A has 1 to 25 letters, and the person needs to draw a line between 1 to 2 to 3 to 4, whereas B has both alphabets and numbers. It has 1 to 13 numbers and A to L alphabet, and the person needs to do 1A, 2B, and then continue. So the scoring in general, the scoring limit is 40 seconds for a test A and 90 seconds for the test B. But the average generally people score is 29 seconds and 75 seconds in A and B. If the person does a test more than 78 seconds, so that means his attention span is really really low. It's deficit in case of trial A questionnaire, and whereas if it's more than 273 seconds, it's trial B questionnaire. That's all. Thank you very much.
Can you unshare your slide? I think Parul will appear soon. Yeah.
So I request Dr. Gujral to comment on our presentation.
Yeah, that was a really nice brief overview of a neuropsychological assessment. There was a lot of information in there for those of you who are not familiar with neuropsychological testing. I think it's a little difficult to grasp your mind around, but Ms. Sheetal did a really good job explaining how the goal of neuropsychological assessment is to assess brain behavior relationships. And but we are assessing behavior through these tests, and we're making inferences about areas in the brain where you might be having problems. And what I was thinking I could do is just, that was a great brief overview. What I can do is just expand on what a typical neuropsychological assessment is like from a clinical experience and then from a research perspective, because I do both clinical work and research in this field. And so some of the tests that Ms. Sheetal discussed are commonly included in neuropsych assessments. So what we try to do, just to start at the beginning. So who do neuropsychologists see as patients? So this is a consultation service. So someone's primary care doctor or neurologist or psychiatrist, they would refer someone for a neuropsychological assessment if they have concerns about either cognitive decline or some sort of cognitive problems the person is reporting as a change from their baseline function. This could be, most often I'm forgetting things, or I'm having some sort of memory problems. It seems that to the common person, memory is the only cognitive domain that most people are aware of, because some of these other things that we talked about, attention, processing speed, executive function, it's just not kind of in the common language. So most people come to us with, okay, I'm having some memory problems, or I'm not able to concentrate. And so the most common issues we see, or causes for cognitive problems, are things like people with some sort of traumatic brain injury, attention deficit hyperactivity disorder, so ADHD, which has childhood onset, or in later life dementia. But oftentimes people come to neuropsychologists, but they're really having cognitive problems due to psychiatric issues, because they're depressed, because they're anxious. And that's actually one of my areas of specialty. It's difficult to tease apart, are you actually capable of performing on this cognitive test if you were feeling better today, if you were able to totally engage? How much of it is due to your depression versus an actual problem, like an organic problem in your brain? So that's a very important task of neuropsychologists. And that's why we administer these emotional questionnaires in addition to the cognitive tests, some of which Ms. Sheetal talked about. So this state trait anxiety questionnaire is helpful to understand, are you anxious right now? And also, how anxious of a person are you in general? Is this just kind of a baseline thing for you? So that's important to distinguish. Other questionnaires we typically assess are, just a general depression questionnaire that's apart from the anxiety questionnaire. So there's like a Beck depression inventory that's commonly administered. And for people who have had more chronic psychiatric history, or they've had a lot of interpersonal issues throughout their life, we would administer something even longer, like a personality inventory. So what's most common, there's so many of these questionnaires, they tend to be quite kind of long, but they can speak to more stable trait-like characteristics that might be, affecting your cognitive function. But anyhow, so when we get a referral, just to kind of walk you through the process, when we get a referral, the most important piece of what we do is the clinical interview with someone. So I think Ms. Parul earlier spoke about how, most times these involve, quite a bit of cognitive testing, but sometimes we're able to decipher a lot from clinical interviews. And in fact, during COVID-19, a lot of face-to-face neuropsych testing stopped, right, because of the lockdowns and whatnot. So all we were able to do was do in-depth clinical interviews with patients and defer testing to a later time. But through this experience, what we learned is that we can get a lot of information from the clinical interview, that's important to understand whether there's some sort of organic brain syndrome going on or if it's something else. So in this interview, I'd say the most important thing we try to assess is, has there been a change in your thinking and memory and your functioning and your day-to-day functioning? Because, if you're having some concentration difficulties, but then you're just able to carry out your day-to-day activities with no problem, then you're probably not going to come see a neuropsychologist because it's not bothering you. So that's another important piece. It has to bother you, and it has to be affecting your day-to-day life. So we assess, has there been a change and is it affecting your functioning? And we look at ask about all the different domains. And then we try and get a very detailed history about their current medical problems, their medical history. And just to give you an idea of the sort of things that can affect cognition that we typically assess for, we want to know whether someone has had any history of head injury or any sort of major chronic illness that can affect cognition, like, for instance, cardiovascular disease. We find that after having like a bypass surgery, even 2 years later, that people experience cognitive impairment. In fact, after many surgeries, people experience cognitive impairment, cancer. And we want to know what are your labs right now? So a lot of times it's really important for, we'll recommend that primary care doctors follow up on things like your vitamin levels, because vitamin D, B12, all of these things can affect your cognition in the moment. And we want to be able to rule out, is there a reversible cause for your cognitive impairment right now? So is there something that you can do right now by taking a vitamin supplement that could actually, improve your cognition? So it's not something degenerative that's going on, or it's not, it's not something else like that. And then we sometimes recommend getting neuroimaging done. And what this does is gives us an idea, particularly in older adults, but in general, is there anything structurally wrong in your brain? So are we seeing brain atrophy? Are we seeing neurodegeneration? So how that's typically assessed is looking at hippocampal volume. So the hippocampus is an area of the brain that's very important for episodic memory. And in Alzheimer's disease, for instance, we see a lot of shrinkage of the hippocampus, and we see more generalized brain atrophy. So just kind of shrinkage of the overall brain and a lot more spaces when you look at a brain scan. So that helps give us an idea of, is there structural brain loss? Another reason neuroimaging is useful to us is due to small vessel disease. So what that is when you have vascular risk factors like hypertension, diabetes that we don't think about, these are just kind of common everyday things that most people have, right? Hypertension and diabetes are huge risk factors for cognitive decline as you age. And what happens is over time, you might get it when you're 40, but by the time you're 60, you've had these conditions for 20 years, and it may or may not have been well controlled throughout that time. And for those of us who don't control these conditions well, you can get cerebral small vessel disease is typically what it's called. So what happens is that it affects the small vessels in your brain, which affects the blood flow to different areas of your brain. And there are certain patterns of cognitive problems that we see in people who have cerebral small vessel disease. And in fact, it looks quite different from somebody with Alzheimer's disease. So, part of what a neuropsychologist does is this differential diagnosis. So what is your medical background? And what does your behavioral assessment look like right now? Are you having primarily memory problems? Are you having trouble learning new information? Are you having rapid forgetting? Or are you having trouble with, shifting between tasks? Are you having trouble with problem solving? Are you having trouble with planning and organization? These are executive functions. And processing speed. So processing speed is one of the most critical things that slows down if you have cerebral small vessel disease. It's a really, classic hallmark sign. So if you're having executive and processing speed difficulties, it can be due to cerebral small vessel disease, especially if you're aging and have those risk factors. So that just gives you an idea of some of the differential diagnosis we do. So we get a very detailed medical history, very detailed psychiatric history, because like I said, psychiatric problems can have a huge impact on your cognitive function objectively. Psychiatric symptoms can also have a huge impact on your perception of your cognitive function, right? So if somebody's depressed, they're going to be more focused on any problem that they're having. So they might kind of exaggerate, a small issue. They would be some mild concentration difficulties that on our testing looks like they're just, right where we would expect for their age and background, but then they just feel so overwhelmed with this problem. So it can affect your perception of the cognitive problem. It can also affect your effort or engagement during testing. So that's a piece, we didn't talk about a lot, but it's something that we sometimes take for granted, but we really shouldn't. So when somebody does a neuropsychological assessment. So these assessments can last, depending on how many tests you're doing, anywhere between 2 to 5 hours. So it's quite a long time that somebody has to remain focused and engaged. And so, if somebody is really depressed, or if somebody has a lot of test anxiety, if somebody is very anxious, they're also going to have a lot of trouble truly giving their best effort on the test. And so neuropsychologists often use specific tests designed to assess your level of effort. And what these tests are like, they're very simple, and they've been used across populations. And what we've found is that even patients with dementia can perform reasonably well on these tests, unless you have really advanced dementia. So people with a lot of cognitive impairment can do pretty well. So if we find someone performing at chance, at 50% on these tests, we know that they're just not able to give their best effort. So we have multiple such markers in neuropsych assessments. So we have independent tests like this. One is where we show 50 pictures, one after another, and then ask them to just recall, did you see A or B? We also have other measures of effort that are embedded within our neuropsychological tests. So there are certain, like if you perform below a certain threshold, we know it's not just you're having a cognitive problem, it's that you're not able to actually engage in the testing. So that's, that's a really critical piece of this. The last thing I want to say about clinical assessments is, so there are multiple approaches, but one of the most popular approaches currently in neuropsych assessment interpretation is called the Boston process approach. And what that involves is not just looking at the final score that you get on each test. So what we do with that final score is we compare it with these culturally appropriate norms, right? So we'll have hopefully a large number of people in the population that don't have cognitive problems that we're calling healthy. And we have them do the same test and we compare it to our score to how they perform. But this process approach involves looking at patterns within tests, patterns of performance. So like, at which point in the test are you having errors? Is it early on? What are the types of errors that you're making? Can that tell us something about what's going on in your brain? And so in different tests, there are different things we look for. For instance, on a memory test, common memory test is where we give someone a word list to learn and we repeat it over time and ask them to recall, what did you just hear? Then we'll have a delay, maybe 20-minute delay, and ask them to recall those words again. If we find somebody that just starts having a lot of repetitions, so they'll just keep saying the same word over again, but they're not even realizing they're saying the same word, or they have a lot of intrusions, so they're saying words that were not even on the list. We try and understand, okay, where are these intrusions coming from, or where are these what is this evidence of? So that seems to be evidence of executive dysfunction. They're not able to inhibit their impulse to have, make these repetitions. And these intrusions means they're not accurately recalling the list. Their mind is going elsewhere in the process. They're just trying to draw upon other information that they have. So it just gives you an idea of some of the kind of subtle information we look for in neuropsych tests. And as Ms. Sheetal mentioned, I don't want to take up too much time, but in the research setting, we do tend to use, when a study is designed, a research study is designed, we tend to choose a battery that's appropriate to that population and have to stick to that battery throughout the study because you want to be able to interpret that data for the entire sample. This field of neuropsychology is really in a transition phase right now. Particularly, we talked a little bit about paper and pencil testing. That's been the primary mode of testing up until this point, but over the last decade, there has been a huge push toward computerized testing, as well as what's called ambulatory cognitive assessment, which is like using smartphones and doing brief burst assessments over kind of that are perhaps more ecologically valid over the course of a week, seeing, how your cognition is. So those are kind of like new hot emerging areas in neuropsych assessment. But I think, in the next decade or so, we're going to be shifting a lot more toward computerized testing. But I do want to warn that it is still, some people think doing something on a computer, you'll just get a score. But from what I just said, it's really important to have an experienced clinician who's interpreting the data and observing the patient, because you need to see their behaviors to put this in a context, and it can't just be these computerized scores that come out of it. Well, hopefully that gave you a little bit of kind of context to the neuropsych assessment piece. Don't want to take up too much of your time, but happy to answer any question.
Is there any question from anyone? So ma'am, what is the solution for such problem where individual doesn't want to perform or not interested in giving neuropsychological test answers? So how can we deal with such situation if person mind is somewhere else, because we are at the last looking for the values and going for the conclusions. So how can we deal with such problems?
Yeah, so in the moment, I think it's really challenging because you do have to have a difficult conversation with the participant. So we do these tests early on in a testing session because we don't want to waste our time giving a lot of tests after realizing that they're probably not going to put in their best effort. So people take different approaches with this. Some people, after they do an effort assessment and they find someone does very poorly, they'll just stop the assessment there and say, it looks like, we won't use the word effort typically ever, but to say that, it just looks like you're really not able to engage fully today. And what that means is that we can't interpret your data. It's not going to be valid. So, we invite them to come back at a different time. So sometimes, it might not even be someone's fault. They might be in acute pain or something like that, someone with chronic pain, and they just are so focused on the pain, they can't, they can't do the test. Other times, unfortunately, I don't think for these people that saying that they're putting in less effort in the moment will make a difference. So I think it does have to be like, you have to give them feedback on a different day, or I don't think it'll help them do better on that given assessment. But it's not that common. Usually when someone is coming to you and they have concerns, they want to do their best, right? They want to give it their best because they want you to know what they're capable of doing.
Unless it's a research subject. Unless it's a research subject, then may not have come to you to get an evaluation done, but you are actually studying the intervention and its effects. Then should we exclude such subjects?
Yeah, in fact, so here in our intervention research, I think this is where behavioral observations from the assessor can be very important, these clinical notes that they make. So as the neuropsychologist, when we later, diagnose a case, which we do in research settings, we read all these clinical notes and we determine whether that data was valid or not. And then we do throw out people who we think, were not able to fully engage. Yeah.
Has anyone done sensitivity and specificity investigations and published this of any of the neuropsychological testing procedures?
There is a literature out there, and I can send you, some papers.
And what is the, do we lose on something if we do tele, for example, if we engage you as a collaborator and we have a 12 subjects who are undergoing yoga intervention, another 12 who are not undergoing yoga intervention for 1 month. Do we lose on something if we do not have a physical clinical psychologist like you on the spot, and like you, we engage you over the internet and you ask questions? Have people done those kind of studies?
Yeah. So in fact, COVID has really set the stage for this whole field of teleneuropsychology. There was a lot of resistance to this beforehand because, like I said, a lot of these are paper pencil tests, and and a lot of the materials are also proprietary. So you don't want to be giving it out to patients, so they familiarize themselves with it. But yes, so the teleneuropsychology is, has become, people are learning how to do it well. In fact, in our research lab, we're doing it for our longitudinal and intervention studies. It took a lot to adapt some of these tests for the virtual format. And, there are going to be disruptions if you're doing it to someone, testing someone in their home, for instance. We would still recommend, like, for instance, what we're doing now is people who are willing to come into the lab, we will bring them in, with mask, and we will have them do the virtual assessment in the next room and still do it virtually, so they don't have to wear a mask the whole time, but it's a controlled environment, stress-free, that sort of thing, not dog barking, and that, I don't have those background disruptions. Yeah.
So is there any question from anyone? Ma'am, my last question, how much is the association between these neuropsychological tests and neuroimaging?
Yeah, it really varies. Yeah, I would say they're definitely not.
Let me rephrase that for you. How many times you have, or in general, what proportion of the predictions you make, come up as neuroimaging deficits?
As neuroimaging deficits. I wouldn't give it a sort of percentage. I think it's really variable, and it's based on this field or this idea called cognitive reserve and brain reserve. So based on your early life experiences, like your education, your socioeconomic status, your stimulation throughout your life, that gives you a certain reserve. So what we find is that even if we detect some cognitive decline in someone that's really high functioning, we might not see corresponding brain deficits. It really depends on your own individual background, the sort of correspondence we see between brain and behavior.
Parul, can I ask another question?
Yes, sir.
What I want to ask you is, if you want to study if a certain yoga intervention is able to halt the conversion of MCI, cognitive impairment, into a full-blown Alzheimer disease, what would you recommend should be the battery we should use? Let's say a 3-month intervention in prisoners. In fact, this is what we are about to start.
Okay. So 3-month intervention in prisoners. So these are all older adults then? Are they older? They have MCI?
We have to detect MCI and then give them the protocol. That's the inclusion criteria. So for MCI, what test we choose and what age we choose, with the limited prisons, maybe 15 prisons in northwest of India. What would be the study design, whatever you can think of?
Yeah. So this is to detect MCI. So I'd say it's important.
Without imaging, of course.
Without imaging, yeah. I'd say the first thing is it's important to assess each cognitive domain. So make sure your battery involves each cognitive domain. So some brief batteries that we use here are the R bands. It's called the repeatable battery of neuropsychological status. That gets at many cognitive domains, and it's very good at assessing memory. But what it doesn't get at much is executive function. So a lot of times in our research studies, we'll use the R bands, and then we'll add a couple of executive tests like the trail making test that we talked about, some sort of problem solving test. The Wisconsin card sort test is a very good problem solving test. There's also like inhibition tests that are Stroop-like.
Or the mini mental test?
So the mini mental test is a screener. So that is a 5 to 10 minute cognitive screening instrument. It's not very sensitive to MCI. And if you have to only use a screener, which I wouldn't recommend for MCI, I would use the MOCA over the mini mental status state exam. Yeah, so I would make sure you get all domains, but you also want to think about most of your tests being co-normed. So that means, they've been normed, all the tests have been normed on the same people so that you can compare across domains.
What does that mean? Can you?
Co-normed means that all of these tests were administered to the same people. So you have, when you're comparing to a healthy population, that healthy population received all of those tests together, and you're rather than one population received one test, another population received another test. So you're just kind of making comparisons that are kind of apples and oranges.
Yeah. Sheetal, would you like to ask any question regarding your own project that you're planning, or any of the tests that you showed? You had any doubts about?
Yeah, ma'am, I just wanted to ask you a question, as I'm doing high altitude studies, so how neuropsychological tests can help, because people who go on high altitude, so there is a stress which is built up because they're going on a very high altitude and things like that. So how can neuropsychological tests help in that time when the SPO level is different and people are, so what kind of a stress they have or otherwise?
Yeah, these people are just flying in without any support for acclimatization, and they suddenly land and they may be undergoing hypoxia, and it is reported that they may have pulmonary challenges and hypoxia, and they have to stabilize for 3-4 days.
Yeah.
That time,
so
if you want to look at, if you want to see if there are any deficits, and if those deficits can be compensated by a yoga intervention, in the same battery will be recommended, the executive?
No. So that would be a very different battery because that's an acute situation, kind of a reversible cognitive impairment, right?
Okay.
So you would use some more basic assessments depending on, some briefer assessments. First, you want to do like a neurologic exam, kind of looking at all their, are their reflexes working okay? Are their motor function working okay? And then you want to look at, do a cognitive screener first, see, are they having any problems on the screening exam? And if they're having some problems, you might follow up with some additional tests. But that's going to look like a very different sort of test. It's similar to like if someone underwent surgery and post-surgery, you're seeing, are they, is their cognition okay? You're just going to do a brief assessment to assess that. Mm-hmm.
Thank you.
Mm-hmm.
Is there any questions from anyone? So thank you, Mrs. Sheetal, for nice presentation about the different types of neuropsychological testing, and thank you, Dr. Gujral, for suggesting the importance and significance of these tests in clinical settings as well as in research. Thank you very much.